All right, thank you all for being here today, and I'll try to keep this to 15 or 20 minutes so we have room for discussion. So my name is Ala Abdel Said, and I go by Al, and I'm the Medical Director of UW Health Pain Services and Chronic Pain Management. And our main talk today in my slides will be about the use of opioids in the post-surgical patients. And we will talk about how can be like having a surgery is the main problem and the main or first exposure to a patient to opioids, which can lead down the road to opioid tolerance addiction or continuous use unnecessarily. And then we're going to open at the end for questions. So any questions you may have, we'll be able to talk about whether related or unrelated to the same exact topic. These are my disclosures, which have nothing to do with our talk today. And looking at the statistics here, millions of Americans actually continue to use their opioids beyond even the surgical recovery period. So it's been very common practice that patients will have surgery and then they will get certain number of opioids for surgical pain after surgery. And I think it's different between different institutes, but the number of pills can be constantly really high and sufficient maybe for several weeks, while maybe the surgery is not very painful. And there are many problems around this topic really, is if you don't give enough pain medications for patients, their satisfaction scores will go very low and patients will complain about pain after surgery, or they will start going back to the surgeon for refills and the surgeon will be busy with other things other than pain management after surgery. So it's been more of a habit and a practice all over the country that patients after surgery just get a certain number of pills to make sure their pain is very well controlled after surgery. So this is actually millions of Americans were found to continue the use of their opioids beyond the normal recovery period, and that's from national data. And the high percent of those patients actually received opioids for the first time of their life. And this is a very important point because some of those patients, maybe this will be their first exposure that will take them down the road to addiction and more other serious problems of opioids. And I know people in person and patients in person and by statistics that really, they try just opioids after surgery and that's kind of their path to addiction afterwards. And also, this research specifically identified 5,276 patients who developed persistent drug habits and continued filling their opioids for 3 to 6 months actually after their surgery took place, which usually that's way beyond, honestly, the recovery of any surgery. So 69% they found that surgeons were the highest prescribers in the first 3 months. And that makes sense because the surgeons take ownership of their patients and the patient come back after surgery complaining of pain. So they do prescribe them with opioids to continue the pain management. And this is actually a very also important finding because the first 3 months after surgery, the patient is still like by definition in acute pain. So usually chronic pain clinics don't like to see the patients before 3 months because that's the definition of chronic pain, is that if you continue to have pain for more than 3 months, that's becoming a chronic pain issue. So the first 3 months are usually the challenging really duration where most of pain clinics will not be accepting patients around that time because this is a more acute surgical pain. So the surgeons will be the ones really followed by primary cares, which makes sense too, because if the surgeon is busy or decides, start seeing your primary care to transition back to your regular life. So the primary care will be the one who is carrying the burden of prescribing the opioids at that time. But when it comes to 9 to 12 months after surgery, the majority of opioid prescription come from actually primary care providers. And again, that's probably a predictable finding because after recovery, patient will continue their care overall with their primary care physicians who will take care of pain as part of the whole management of the patient, other problems. So in 2017, there were enough opioid prescribed to supply every person in the US with 32 pills, which was a slight decrease actually from 2016. And that's another important finding because we all thought that after 2016 and the CDC guidelines and all this media talk about opioids, prescriptions, overdosing, killing thousands of our citizens every year, everybody really expected a dramatic decrease in the opioid prescriptions to follow this great media work. But actually it did decline, but not that much. And while every state in the country reported a drop in the opioid use actually in 2017, many of them actually were not significant decreases. I'll take this example that actually stop opioid prescribing state recorded 10%, but 10% didn't really make much sense because it was down to 65 pills, which is still very high. Again, they come from a higher level compared to other states in the country, but it's still high. So while we think and we hear always about decrease in opioid prescribing habits across the nation, so they did not decrease as we think. And among 7 surgeries, actually total knee and total hip, with the major 2 surgeries that they found that patients really take high dose opioids. And there was decrease from 85 pills per patient to 82 pills, which not a great decrease. And again, it's very important to notice that the number of pills is not the only variable we deal with, because there are very potent medication, opioids, and there are stronger opioids than others. For example, if I say codeine as compared to oxycodone. So the numbers of pills may not be the only indicator, but you might deliver less pills, but a much stronger, higher potency, higher addiction can the potential pills. So actually that makes the problem worse, not improve it. And it was found that 1 in 4 orthopedic patients received a prescription in excess of the 90 morphine equivalent, which is the recommendation, the recommended high dose by the CDC. And the average rate of later opioid dependence and addiction among surgical patients kind of was around 12%, and again was higher at TKA. So 17% following colectomy, 15.2% following TKA and total knee arthroplasty, and 9.5% for rotator cuff surgery. So these are very high numbers for a patient who probably try opioids for the first time after surgery and then develop addiction because of this first exposure. Women were found to be at higher risk than men of to be persistent users, and we see this finding mostly in the chronic pain environment, that women tend to have higher pain than men. And now I would like to share with you just some work done at UW to see if patients start opioids after surgery, how many will actually use it and how many will not use it. So this was actually done by some colleagues at our pharmacy department at UW, where basically they developed a questionnaire and they identified patients who had surgical procedures. And they send them the questionnaire and the expected responses about their habits and need of opioids after surgery. So they got 50 patients and 36 responses. And the procedures was mainly 68.7% laparoscopic procedures. And then they start looking into the median discharge pain score was about 3, and at home was around 4. And they found again the mean opioid discharge quantity was 47% tablets. And the surprising number here, percentage of opioid prescription unused, was 67.2%. So 67.2% of the patient who got opioids after surgery did not use their opioids. And we can always come up with the conclusion, are those pills sitting somewhere at home, within reach of friends, kids, vulnerable populations, teenagers. So that's really what creates the problems, having pills sitting around within reach for people who maybe shouldn't be reaching out to those. And actually this finding has been confirmed later in other surveys done across the US. The number was around 60 to 70% of patients that actually do not use opioids after surgery. So those are people who are unused. On the other side, we have more than 30% of patients who will be using their opioids, sometimes necessarily or unnecessarily, maybe develop addiction down the road. So the problematic figure here is way higher than the 67.2%. But that shows you that not every patient actually will need opioids after surgery. And 56.2% of patients reported their pain to be mostly fully resolved at the time of the call, which was really few days after surgery. And 53% of patients described their supply of opioid pain medication to be excessive or slightly too much. So the patient themselves, more than half of them said, they gave me too much after my surgery. And this is kind of distribution of what the surgery that was included. It's all across the board here. And now we'll talk quickly about the transition clinics, because the problem here is the surgeon will do a surgery and then this patient will go out and what if we don't give the patient opioids and then they need opioids? Because that's possible that they will need certain dose of opioids following the recovery or during the recovery. So it's a problem here, because you go back to the surgeon, refill opioids, or go back to the primary care and refill their opioids. But there is no big comprehensive foundation that will evaluate the patient and use non-opioid measures, because pain control after surgery is not only opioids. Maybe opioids is what needed in this patient population, but there are too many other modalities that can be used at many other classes of medications, nerve blocks, regional anesthesia, and this all can be planned actually before surgery. So in some other countries, I would say specifically Canada, they started experimenting a transition clinic, which means a clinic that will take the patient after surgery and transition them to recovery using anesthesiologists, rehabilitation, psychologists, psychiatrists, all kind of means to treat the pain of those patients. So that was a study done at Toronto General Hospital. And this is a figure that you don't need, we're not gonna go through it, but it shows you how many people are involved in the pain management following surgery. So the concept of opioids following surgery, or opioids overall in pain management, is not really the modern medicine. Because there are many things, patients after surgery may have depression because they can't move, they can't go socialize, they are missing on events. They probably need to see a psychologist. Some people probably on chronic opioids before surgery, and maybe they need to help from regional anesthesia, getting nerve blocks, going through surgery, use non-opioid measures. And there are patients who are at high risk of addiction actually, and we never screen those before surgery, because those are patients who probably high risk of addiction, and there are questionnaires to show that they are high risk of addiction, probably shouldn't have opioids after surgery, but have other measures like anti-seizure medication, neuropathic agents. We talk also about the acetaminophen NSAIDs, which by the way were found to be stronger pain management modalities than opioids. So this figure just shows you it's way beyond having a pill after surgery. There is a lot here to consider. And what about patients who will seriously develop chronic pain after their surgery and they need chronic pain care? So it's more beyond the 3 months that they need to see a chronic pain specialist rather than their surgeon or primary care. So it's the issue of this figure is just to show you we need really like a big team to address the pain after surgery, because it can be the end for some patient. They develop addiction, and I know personal stories of people who develop addiction, end up killing others, going to jail just for using opioids after surgery. And when you see one of those stories, you really see how great the work actually Jonathan and others are doing, educating people, because one life is too many, and we see this in thousands of patients. So this is kind of show you it's a collaboration between the pain, primary care, surgeon, psychologist. Those people need to communicate. So that's what they call the transition clinic, basically a transition clinic to transition those patients back to normal life using and coordinating with all those individuals in the healthcare system. And this is another slide that will show you that the cost of actually treating post-surgical pain is actually extremely high. It's $41,000 per patient per year. So this is a very high figure. And if you see how many surgeries we do in the US every year, this is going to be billions of cost for treating just chronic post-surgical pain. And again, this here we talk about patients who they have pain to continue for several months to a year after surgery. That need to be really addressed by a multidisciplinary team that hopefully exists in every single institute. And so again, this group actually evaluated their patient, their major surgery, and they communicated with a big group of of providers to address the pain at different aspects. So again, think always of the comprehensive nature of pain management in acute and chronic post-surgical pain. And they determined that their 3 primary goals is to provide a novel approach for pre- and post-operative pain management. And this is very important. The pain management need to be actually planned before surgery, not after surgery. Again, due to the patient who will go into major surgeries, patient at high risk of addiction, patient already on chronic opioids, or How about recovering addicts who are going for surgery? So this all has to be addressed before surgery. So this transition clinic basically saw patients before surgery, made a plan, and then they managed the opioid medication for complex patient after discharge. And the third goal was improve patient coping and functioning. And this is another very important piece here. Pain is not about taking pills and being no pain and sit in your recliner all day long watching TV. You need to be functional after surgery, participate in rehab and physical therapy to regain your function. And again, their team, if you look at this slide, formed of 5 anesthesiologists, 2 psychologists, 3 acute pain nurse practitioners, 2 physical therapists, an acupuncture specialist, a palliative care specialist, a psychologist, patient care coordinator, and administrative assistants. And honestly, you can add and more to this list of people who will be involved in this process. And their transition clinic service had actually certain referral criteria, because sometimes it might be hard to see every surgical patient before their surgeries, because let me say, an athlete who's going for a simple knee surgery will be happy having opioids for 3 days after surgery or some acetaminophen, ibuprofen. That's probably not our target patient here, but we talk about patients who will be really complex that will require extra care to make this a more sustainable and doable service. So they looked for patients with preoperative chronic pain because these are high risk, intense postoperative pain expected, prolonged acute pain service stay, patient with intense pain, and patients requiring a repeat acute pain consultations, medically stable patients unable to be discharged due to complex pain problems, high postoperative opioid consumption, patient who consume more than 90 milligrams per day, patients admitted on methadone or buprenorphine, patients discharged with a prescription for long-acting opioid, patients needing interventional post-surgical procedures like catheters or post-amputation, patients who are in emotional distress, depression, and anxiety. And this is very important. This can be the whole problem. Sometimes it's not really pain. It's just more the emotional stress and anxiety, lack of family support and social support at home after discharge. And it's in several instances, we all see it, we get called in the post-operative recovery unit about the patient pain, but he found the whole thing is really an anxiety. And once he gives them an anxiolytic, the pain is becoming a non-issue. So there's a very big overlap here in the picture of pain or emotional distress and anxiety following surgery. And about the monitoring, we use actually in Wisconsin at UW to monitor kind of the opioid consumption for patients, and what providers do is the PDMP system, which now is becoming a requirement. If you want to prescribe beyond 3 days, you have to check the PDMP. And it's not about only policing really patient or physician, but sometimes you look at the PDMP and you as a provider, you get very concerned about the PDMP. You find this patient on high dose opioids, going to multiple providers, multiple pharmacies, maybe multiple states, particularly we sit sometimes practice with other border states. So it can make you as a surgeon or a provider really concerned about giving post-operative opioids for this patient. So it adds another piece of information to guide the management, and also to monitor the patient and the provider, make sure nobody is over-prescribing or over-consuming. And then our institutional effort included, and also state efforts, and probably these are efforts done in multiple institutes as well, is developing opioid guidelines to make sure people just understand the state guidelines, CDC guidelines of safe opioid prescriptions, and use also of appropriate questionnaires to identify patients who are at high risk of addiction or tolerance. Then actually multiple QI projects and great work done by Johnson and Randy Brown and other colleagues at UW that just take this really time and effort to teach people on opioids and how to handle pain otherwise other than opioids. And that will be in the series of sessions you will have during this project. Because here we talk about the problem and some solutions, but maybe we need more action about having really providers who will be available to do the nerve blocks, prescribe the non-opioid management, screen the patient. We need great nurses for educating our patients after surgery, social workers to address all the social issues after surgery. And then there is actually good effort from our pharmacy department here about developing an opioid calculator to make it a quick tool that you can calculate the opioid equivalency if you decide to prescribe beyond hospital stay. And then the multidisciplinary pain approaches, which I think have been very successful really at UW, because We do have inpatient consult service. We do have providers inpatient. We have actually one of the biggest pain programs as an outpatient, where we have in our chronic pain program, we have psychologists, psychiatrists, addiction counselor, rehab, anesthesia, advanced pain practitioner, infusion center, procedure rooms, EMG capabilities. So basically the patient can go there and find all services in one place. So we made it available in the inpatient and outpatient. And I encourage everybody here coming from a different institute really to reach out to us, and because it took us here to develop this setting, so we can share experiences and hopefully can develop similar setting in your institute, which will make it very safe for both the provider and the patient, will improve outcomes and reduce the issues of opioid prescribing. And I would like to share with you my book that I recently published on chronic pain and safe practices, why we shouldn't prescribe opioids, psych support and family support for chronic pain, which really applies also to acute pain and post-surgical pain, and any patient in pain who might require non-opioid management support, that I hope it will be a resource if you need a resource. Again, thanks so much for your time, and I'll be happy to take any questions right now from anybody on attending this session.
Fantastic, thank you so much. I will stop sharing here. And again, if you've got questions, just feel free to unmute and ask them, or if you don't have a mic or don't like using the mic, we're happy to take your questions by chat as well. Any questions that leap to the fore? I have several, if nobody there has anything that immediately leaps to mind, but please, what are your thoughts? And what are you seeing out there? What are the problems your facilities have?
So this is Lisa from Spectrum Health in Grand Rapids, and one of the things my primary job is actually as our orthopedic CNS, so I see a lot of my patients in your slide presentation here. But one of the issues our surgeons have is not really understanding how to teach patients how to taper their medications. And I'm just wondering if you guys have found anything successful or helpful in helping patients and surgeons have that conversation about how to taper, how fast to taper, especially these patients who really kind of get toward that, 6 to 12 weeks of taking pain medication.
Lisa, thanks so much. Actually, that's an excellent and very good question. And we encountered this problem at UW actually a few years ago. So the first thing is always in orthopedic surgery specifically, try to use non-opioid pain management. I think working with regional anesthesia team can really, they provide blocks for all kinds of orthopedic procedures. So that's one important thing, to collaborate with the regional anesthesia team. The second thing, we developed actually what's called the e-consults. So we all the time get questions from our surgeons, our orthopedic surgeons, general surgeons about, I have this patient after surgery. So the patient doesn't have to come to the clinic and the orthopedic surgeon doesn't have to give us a call or chase us around. But we did what's called the e-consult. They send us an e-consult and we send them clear instruction on how to wean down the medications after surgery and what other modalities they probably can use other than opioids. And sometimes we tell them, you know what, if you're really struggling with this complex patient, send them to our clinic and we will take care of it for you. And this support has been very highly appreciated, and I'm not sure if we provide it outside UW Health, but that's a very good model to develop in any system.
Here we've got a text from Joanne Wagner Novak. So post-op pain, ortho doesn't like to use NSAIDs and avoid them for 8 to 12 weeks. Are there any studies looking at the musculoskeletal effects of NSAIDs versus opioids? And we actually just had a session on this. Yes. We run a session for pediatric emergency or pediatric surgical care, similar to this, where we talked about the same thing. Because I remember as a resident being told, when I was an intern on the orthopedic service, being told you mustn't ever give ibuprofen to a patient with a fracture, because in rats it decreases bone healing. It's probably the best quoted, most implemented rat study in history.
That's correct, actually. And we always, when we have an orthopedic surgery patient, we ask, can we give NSAID after surgery? If the pain is severe and depends on the surgeon, they tell you yes or no. It's still, I would say, a controversial area. I don't think there is like a clean-cut study that said absolutely don't give ibuprofens or NSAIDs following surgery. But I would think if the surgeon is, I mean, again, depends on the pain and then the setting and on the surgery. Definitely, if I have a high-risk patient, I just treated the fracture, I'm worried about healing. This patient have 10 other risk factors for non-healing, probably I'll avoid NSAIDs. But if I get this, 18-year-old healthy adult who healed, athletic, muscular, and will be fine, no other comorbidities maybe, I think it's measuring the risk and benefit here, there is maybe more benefit. But using acetaminophen IV has been actually very effective as well. And then using the neuropathic agent, which is something we always forget about, like the gabapentin, pregabalin, amitriptyline, the TCAs. All of those are very good, actually, medication that can be used in the acute setting. And there is very good literature support the use of gabapentin in surgical patients and pregabalin. So there are probably, like I mentioned, 5 drugs that can be used. And then comes the role also of regional anesthesiologists who can place catheters, do nerve blocks that probably don't need actually medications at all, using those things. So there are still, even if NSAIDs are not an option, there are many other agents and procedures that can be used in the surgical patient to treat pain before I decide opioids or NSAIDs.
Other questions? While you type, so I think it's so important to think about opioids as not just a pill and sort of one-stop shop for pain control, right? And I think that certainly as I think about my training, and heavens, I mean, I think back to the trauma patients that I would prescribe for, where you'd say, well, this is how many oxycodone they're taking today, and so we're going to just multiply that by 2 weeks, and then they'll just taper themselves off. I mean, I wrote prescriptions for 200 Dilaudid tablets, discharging patients from the hospital. And it was because, so often you were just treating the number of like how many opioid pills to write. But this idea that you need to think of it as a more comprehensive problem with pain, and the idea of this transitional pain clinic, you talk about that and it makes so much sense to me. But I guess to finally drill down to my question, we clearly can't have every patient who undergoes an operation also come in for multiple pre-surgical visits at a transitional pain clinic and multiple visits post-operatively. How do you identify the patients who are the most at risk for having a problem with opioids?
So that's a very good question, and you're right. And as I mentioned in my slides, to make it a sustainable service, you can't just have everybody be seen, but developing selection criteria. So in Toronto, I just presented their kind of idea about the selection criteria. But there are actually many things we can do to identify those patients. One of them is questionnaires about risk of using opioids and means of it. These exist in addiction, and having the history of addiction. If somebody tells you, yeah, I was an alcoholic, or I was an addict before, or I'm a recovering addict, or by those questionnaires show up to be high risk of dependence or addiction. These are easy ones that definitely need non-opioid management. And then there comes many other factors that if this patient will go into a major surgery, that those patients will hurt for a while. These are the patients who need a plan to add other things to opioids to make sure they will transition safe from them. And one of the main important things actually, which I think we're lucky here at TW, to have a resource. Because you get residents doing this, you get fellows, you get surgeons, everybody's busy running around. Having a resource, and that's why we established the e-consult model, is that we get people just call us and send those consult all the time about how shall I win opioids for this patient. And at certain points, they tell us, yeah, I know this patient within the 3 months period, but I really need your help. So we tell them, just send the patient over. And hopefully the transition clinic is the way I perceive it. It doesn't have to start like you hire those 10, 15 people at once, because that's not going to happen anywhere. But more maybe having, for example, 2 nurse practitioners sitting in a pain clinic where you have all the support around, start building around this small foundation, a bigger foundation over time. Use resources, call our inpatient psychologist, addiction providers to help out with the process, and the inpatient pain consult. So these are all tools. So knowing, the screen those patients initially and make sure they see somebody before they go to surgery, or if it happens after surgery, utilize the other expertise to basically have a plan for a patient for post-surgical pain control.
Yeah, I think about that. the work that we've done here and some of the work we've done within the surgical collaborative of Wisconsin, one thing that comes out a lot is that attending surgeons frequently don't know how much pain medication their patients are being prescribed. Correct. Because it's being done by residents. Yep. Or PAs, and one of the first things we did here was to actually look at what was being prescribed to patients and the variety between attendings and between services, and then to look at how many patients called to ask for more pain medicine and whether that correlated in any way with like how many they were prescribed. And I think you sort of showed in your data too, patients actually, it turns out, don't use very much and actually would prefer to be prescribed less.
Correct.
A lot of the time.
Correct. Actually, more than half the patients will tell you, oh, I don't want to use because of, honestly, the media did great work on the problem of opioids in the recent years. So they tell you, I don't want to be on those drugs. Also the teaching piece, because there are many patients, so when you prescribe opioids PRN, they think you have to take it every 8 hours rather than it's actually, if you need it, take it. And we started developing actually education script for our nurses here and kind of more, because the nurse really, I think, is the one who come in the closest to contact to the patient in the post-operative setting, because the surgeon just continue operating. And so the nurses really, and they are out of anesthesia. So you need really the nurse who teaches the patient, teaches the family, because you want to make sure this message. But a lot of the time they tell me, I see the patient after surgery and they say, oops, I thought I have to take it every 6 hours. So they think it's actually a prescribed medication, not an as needed medication. So I think education and community, and there are a good literature and patient initiative, and I'm writing an article on this actually as we speak, that shows if you implement those education programs, actually the whole problem just declined by just education. Knowing that you don't have, and there are very good education programs developed in other institutes, and we're doing some here, but we didn't measure outcomes, where just the education itself only succeeded in reducing the opioid consumption without using anything else.
Yeah. I talked to some of our pharmacy folks here about this, and they had done interviews with patients in pharmacies who didn't realize that the medicines that they'd been prescribed were opioids.
Oh, yeah.
They didn't even know they were taking an opioid. They just got a medicine and it said, take this.
Every 6 hours or something, yeah.
Off they went, right? We assume so much, like PRN means something to people who aren't in this business.
And I saw a patient, it's probably a rare incident to happen, but I saw a patient who's been using opioids for years. And the patient told me they gave it to me after surgery and they never stopped it. So the patient, actually, when I told them, let's sweet down, and say, oh, let's sweet down. I didn't know that. I don't need, and it was like 10 years. So sometimes the things, miscommunication and miseducation, if you hit, okay, you left the UW and you had your opioids, and then you go to primary care, maybe in up north in Wisconsin, where they don't have much resources, you continue the prescription. And sometimes the discussion and education just disappears from the whole setting. And you find that the patient themselves say, why am I using this all those years? But that's probably a rare incident, but that shows you how far it can go.
Yeah.
Hopefully some will be caught around the 9 months or 12 months when you figure out what are we doing here and do we need this anymore.
That transition, right, from surgery to primary care or surgery to chronic pain, I guess I hadn't realized that 3 months was the defined cutoff, but that does happen, right? So we prescribe in surgery a fixed number, and then patients, we don't see them back and we think, oh, okay, well, I have no chronic users because I don't write any refills on these, but these are getting filled by
primary
care or
somebody
chronic
else.
Pain docs. Yeah.
Yeah, so this is what the statistics showed actually, because within 3 months, that's by definition acute pain. So most chronic pain clinics say that's more like still a surgical pain or healing pain. So it goes back, depending on where you practice, sometimes a surgeon or the primary care will continue because the patient has pain. And that shows you the importance of communication. But we develop, again, this is a good opportunity to shed some light on our care model, where you actually can send your note to all providers who are caring for the patient at UW. We send it to the physical therapist surgeon, so at least people know what's going on. And it happened that during those conversations, sometimes when I get a note, I will email back the primary, no, please. We already discussed with the patient, don't give them any more opioids, because it's different story everywhere you go, and sometimes there is need or no need. Or so this communication thing that we developed, the specialty care team on HealthLink, is an amazing model that hopefully will be adopted also.
Yeah, that's more than what you get with just the PDMP. But even in the PDMP, like you get an idea. See that like people are still
I personally have
using?
patients, actually, let me give you this example. We placed the intrathecal pumps and we really transitioned them from very high dose opioids to like zero because it's all delivered through an intrathecal pump. And we send a clear message to everybody, okay, this patient, no more opioids. And then the patient will change primary cares and things will happen. And we check it. I tend to check it every few months if I can. And then one day I found this patient find a new primary care provider and started getting huge dose of PO pills. And then so the primary care provider maybe just didn't know also, like, because I'm not sure if the intrathecal medication will show up on the PDMP. But the communication that happened, that when I check the PDMP myself, I see, no, this has to stop. Or actually sometimes if I'm after surgery trying to give a patient pills, I check the PDMP because I do some implants, some surgical procedures. So I find that this patient is going, already have like got just pills last week. So actually checking the PDMP, as much as sometimes we don't like it in the middle of a busy day, it can actually protect everybody and it can really lead to good management. And right now it's integrated in our Health Link system that you click, you don't have to put passwords or ID, but it does sometimes protect certain patients from overdosing.
Yeah. What are your thoughts on disposal? Because I know that's a huge challenge too, right? You go home with 100 pills, you take one. This happened in my house. And now you have 99 pills. And what do you recommend? And what can we do to help patients get rid of these more easily and not have them sit in the bathroom cabinet for years?
So we're developing, that's another important point, because some patient actually will be good that I don't need those pills, I can dispose them, but they don't know how it sits in the cabinet for a while. And then, patient, if you don't dispose it immediately, you may develop pain after a soccer game in 2 months and you start taking the pills for, that's still quoted as misuse. So I think part of the education now we're trying to develop is for the post-surgical patient and our chronic pain patient is we give them all the ways of disposal. Either come back, do pill count, or go to the police department and drop them in a drop box, or flush them and report it, or something that get rid of the pills, don't have them sitting in your home. So that's again about education, because honestly, if you're not in the medical field, as you said, you take the pills. So as a good patient, you don't know where to put them. Sometimes you just like them, but you don't know, like it's not a very common public knowledge that people know where to take the pills, or dispose them. So that's another education effort that we're trying to develop for the post-surgical patient about that's how you dispose your pills if you don't use them.
Yeah, I think another opportunity for that sort of pharmacy intervention, or the nurse, right? Like who does that final discharge education.
Yes, exactly. And even when you at the pharmacy and in any retail pharmacy, they should probably provide the information associated with opioids. That's how you should dispose them if you decide not to use them.
What are the resources you would recommend? And we can post things on our website. We can direct people places, or if you want to just sort of have on the top of your head ideas for good resources for people to go to if they're looking to improve the pain practices at their hospital.
So definitely, I mean, reading and education are the main two things I think effective. Just go around. I think each system needs a champion who will develop a team and start going all around the system, do community approach, and teach patients on good, safe, like pain management. Actually, if you look pain management literature, opioids come really at the bottom of the list. There are too many other things to be done before you start opioids. And use actually guidelines, develop policies and guidelines in your system. This way it's published, everybody knows it, and provide the resource, which is extremely important because it's not always 1 + 1 = 2. You can't give people guidelines, policies, educate them, but they will encounter situations which are beyond their skills that they need to ask somebody. So maybe have actually a phone number to a pain clinic or a champion or like e-consult, develop a resource. So this way people don't feel they are left out. And again, you use any education material, readings, help people understand how to handle pain.
Fantastic.
So if you're you're out in the community and you're prescribing pills, what would you tell patients is the best way to dispose? I mean, I heard that flushing was actually not recommended. So
so the best way I always find myself feasible, easy, I tell the patient just whenever you have a minute, come back to the clinic. We'll do a pill count. And this way, actually, it's best because we documented that actually the patient brought them back. You can say I flushed them and you didn't flush them. I mean, it can, but bring them back to the clinic, and we don't have to come immediately if you don't use them. Just whenever you just by the area, stop in the clinic and we have a nurse. Actually, it doesn't require even like a big deal. Just call in the morning, say I'm coming, because it's a short thing, and nurse will go document on a piece of paper that this patient returned those pills. It's and documented in the patient chart, which looked very good for the patient and for the practice. And the pills now is in a safe place. I find it the easiest.
Yeah. That gives you the count too of
exactly
how many patients or how many pills people are using. So,
and it's very easy. You call in the morning, you come. You don't need really. It's not like a big appointment, and it's more like credible that you did actually return the pills. Very simple and very well controlled.
Yeah. That's gives me a chance to plug some of the work that we're doing at the Surgical Collaborative of Wisconsin. So we have an opioid initiative that's part of that. And if your institutions are part of the Surgical Collaborative, you may have started to see this appearing. If they aren't, hopefully they will be soon. The Michigan folks, you've already got one up and running. But we are able to create patient-level reports, or physician-level reports rather, for prescribing practices for different operations. So our initial report was for laparoscopic cholecystectomy because it's pretty straightforward. Not a huge amount of pain, fairly homogeneous, often done only as a single operation, not with a million other things. And so we looked at variation across the state of Wisconsin for prescribing, and it ranges from 0 opioids to 50, 60, 70 tablets.
Yeah.
And there are now they're not exactly policies, but sort of best practices or guidelines around what people are prescribing, which is 10 to 15, and we were able to sort of pinpoint where each individual provider was on that spectrum and where each individual hospital was in its variation. My thought is that maybe that would be a useful tool, at least sort of knowing where you sit. If you just sort of assumed that when you finished training that was what you did, and then you just forgot that maybe practices changed, to see that variation and realize that lots of people are getting away with giving no opioids or very few opioids for operation.
That's true, actually, and this is a very good point. Is that and I mean, in my training, we used to give like in the ED, actually we had a stamp, so we don't even waste time writing. We just keep stamping like 60 pill of Percocet 70, and that was the ED practice.
Yeah.
Right. So I mean, the practice changes and you're right. I think we need to provide people with more resources, guidelines, ideas. And I think maybe a project, I'll give you an idea for a project here.
Oh, please.
Is if you identify each surgery and maybe the average national pills that those patients should take, so at least the surgeons can find the reference. Okay, after the TKA, it's okay, 3 pills might be enough.
Yeah.
Something that people can use and at least have some guide about how much I should give. So this way you have a starting point.
Absolutely. Yeah, that sounds perfect. We'll start tomorrow. Other questions out there?
This is Lisa again from Spectrum Health. I'm just really, really interested in hearing about your transition clinic. We don't actually even have an inpatient pain service available to us. And I'm just curious how you sold it to the institution and got appropriate funding and people to own it and back it. And that seems to be the issue here. Does it fall under palliative care? Does it fall under acute health? Nobody really wants to own an inpatient pain service here, and that's why we haven't been able to get one up and running.
And that's a very good point, Lisa. And trust me, it wasn't an easy sellout, but we did succeed at the end to have the institute. So we don't have an official transition clinic, but we are in the phase of discussing with leadership. But we have a very strong inpatient consult service and support system. And so there are many strategies. One of them is show them numbers and the opioids and the problems and the investigations physicians are going through. And then patient satisfaction, if you tell them, okay, if we don't prescribe it, then the patient will score low in satisfaction. And then I think after all, you show them the financial reward. If you can do a cost analysis about those patients who will keep consuming your health system, going ER visits, if you can get those numbers, you will show them that hiring maybe one nurse practitioner inpatient will save them a lot of money by the unnecessary visits and inpatients admission that the patient use. And actually, if you can type in my email address to everybody here,
yeah.
I'll give you my email address, and to everybody here who want to learn the details, I'm going to put it down here. So please feel free to email me. I will provide you with any resources and analysis we did in our system. I can support you if you want to have anybody in your system chat with me about those things. We have done all of this before, share our experience with others. that can sometimes help in actually having you sell, your ideas and establish a good practice, because we do have outcomes and numbers that we can share with you as well.
Other questions? All right. Well, I want to thank you all for joining us. Again, if you like this session, look for the following sessions coming up over the course of the next few months. Also, as we talked about, the Surgical Collaborative of Wisconsin has an active opioid initiative, scwisconsin.org. We are very anxious to partner with our regional colleagues and even the Michigan folks. I know have a lot to learn from you and have been involved in some of your collaborative work, but the more we can work together on this really horrible problem, obviously the better. If you like the format of these sessions, Randy Brown, who's going to be talking in June, actually runs an opioid session of what's called Project Echo. It's a very similar sort of format to this. His focus is on chronic opioid use disorders, and the link is there. We run 2 other Project Echo sessions out of the Department of Surgery, one in pediatric emergency care for taking care of kids with various acute conditions across the state, and particularly in rural settings. That's designed for pre-hospital and ED populations. And then surgical indications and continuity in kids is our session for primary care doctors who take care of kids who might need operations. And then I run a podcast called The Surgery Set, which you can link to there. And we talk to all sorts of people. We have talked to Al, and we will be talking to him again about his book. So that's an easy subscribe, comes out every couple of weeks. And that is, that's the end of session 1. Any questions, comments as we close? Otherwise, we'll be looking forward to seeing you back again for your second hour worth of credit at whatever of those sessions feel good to you. Obviously, if you want to come to all 7, we would love to see you. So,
one quick question.
Yeah, of course.
Will there be an easy way to see these slides later on?
So this whole session is being recorded and will be available online soon. There's a sort of a week or 2 lag while it goes up on the CME site. So you'll be able to watch the whole session again, including all the slides, when it goes up online. You just won't be able to get CME credit for it twice. And someone had asked about the CME codes. So the CME code is JESJOW, and that's texted to 608-260-7097. I put that in the chat as well. All right. Well, wonderful. Thank you all so much for joining us. I know it's spring break week. Hopefully you're all about to head to the airport and head for Florida. And we will see you in April. Thank you so much.